Assalamu alaikum. Now I would like to discuss about a very important electrolyte abnormality, that is sodium problem. It may be hypernatremia or it may be hyponatremia. Okay, what is hypernatremia? Hypernatremia is an electrolyte disorder. It is characterized by serum sodium concentration more than 145 due to loss of water or gain of sodium. Although the absolute amount of sodium in the body may be normal, low, or high. If we look for the pathophysiology, it may be the organ specific. It may be due to the hypothalamic problem. It may be posterior pituitary problem. It may be kidney problem. Okay, and we know that sodium CNS, so it can cause CNS problem like seizures. Okay, now now I would like to look how we can evaluate. We can talk plenty of things regarding hypernatremia, but for exam purpose we need to know the specific thing. Like if somebody comes to you with hypernatremia, that means if somebody comes to you with serum sodium more than 140, 145, sorry, serum sodium more than 145 milliequivalent. If serum sodium is more than 145 milliequivalent per liter, then we need to do assess volume status. Volume status exam includes jugular vein pressure, skin turgor, orthostatic vital sign, and evaluation for edema. If serum sodium is more than 145, then what you need to do? You need to do assess volume status. How we can assess volume status? There are four markers for assessing volume status: jugular vein pressure, skin turgor, jugular vein pressure, skin turgor, orthostatic hypotension, and finally evaluation for edema. If it is hypovolemic, if it is hypovolemic hypernatremia, hypovolemic hypernatremia, then what you need to see, that is total body free water. In hypovolemic hypernatremia, total body free water is decreased and total body sodium is also decreased. If total body if total body free water is decreased, total body sodium is decreased, then you need to see the urine sodium. If urine sodium, if urine sodium is more than 20 milliequivalent per liter, if urine sodium is more than 20 milliequivalent per liter, then it is renal water and sodium loss. It is renal water and sodium loss. It is renal water and sodium loss. It happens due to diuresis and natriuresis. diuresis. If urine sodium is less than 20 milliequivalent per liter, if urine sodium is less than 20 milliequivalent per liter, it is non-renal. Non-renal water and sodium loss. Non-renal water and sodium loss. It may be due to burns and diarrhea. It may be due to burn and diarrhea. Okay, now if it is euvolemic, if it is euvolemic hypernatremia, in euvolemic hypernatremia, total body free water is low and total body sodium is normal. Total body in euvolemic, what happens in the euvolemic? Total body free water is low, total body sodium is normal. It may be again renal loss and non-renal loss. Before jumping into it, you need to do urine osmolarity. If urine osmolarity is less than 30, if urine osmolarity is less than 300 milliosmol per less than 300 milliosmol, it is diabetes insipidus. If urine osmolarity is more than 600, if urine osmolarity is more than 600, it may be due to insensible loss. It may be due to insensible loss. And in hypervolemic hypernatremia, total body water is increased and total body sodium is again increased. So total body water is increased, total body sodium is also increased. It may be due to sodium gain, and in here you need to do urinary sodium. It is more than 40 sodium gain. It may be iatrogenic, like IV fluid, and primary hyperaldosteronism and primary hyperaldosteronism. So this is how we can evaluate hypernatremia. So if a patient comes with hypernatremia, how we can evaluate? First, we need to do an electrolyte, and in electrolyte, sodium level is more than 145 milliequivalent per liter. Then we need to see the volume status. What are the marker we see in volume status? JBP, skin turgor, evaluation for edema, JBP, skin turgor, evaluation for edema, and orthostatic vital signs. If total body water is low and total body sodium is low, that means hypovolemic hypernatremia. That means hypovolemic hypernatremia. Then you need to do the urinary sodium. If urine sodium is more than 20, if urine sodium is more than 20 milliequivalent, it is renal loss, maybe or diuresis, natriuresis, renal water and sodium loss. If it is non-renal water and sodium loss, where urine sodium is less than 20, it may be due to burn, it may be due to burn and diarrhea. And in euvolemic, in euvolemic, total body water is low, but sodium is normal. Sodium, total body sodium is normal. In euvolemic, again you do urinary osmolarity. If urine osmolarity is less than 300, it is renal loss, diabetes insipidus. If urine osmolarity is more than 600, non-renal loss, insensible loss. In hypervolemic hypernatremia, total body water is high, total body sodium is higher, then we need to do urine sodium. If urine sodium is higher, then sodium gain, it may be due to iatrogenic or IV fluid and primary hyperaldosteronism. So in what are the treatment we should give in a patient with hypernatremia? So in here we can in euvolemic hypotonic saline 5% dextrose, in euvolemic 5% dextrose can be given. Hypotonic saline 5% dextrose in hypovolemic hypernatremia. In hypovolemic hypernatremia, like diuresis, natriuresis, if it is symptomatic, yes, isotonic saline 0.9% saline until euvolemic. And if the patient is not symptomatic, hypotonic saline 5% dextrose. So in euvolemic hypernatremia, you should give hypotonic saline 5% dextrose. And if it is symptomatic, yes, if there is tachycardia, hypotension, dry mucous membrane, decreased capillary refill, go for isotonic saline 0.9% until euvolemic. Okay, what is the choice of fluid for initial resuscitation of severe hypovolemic hyponatremia? It is isotonic saline, normal saline, lactate stringer. Using hypotonic solution initially may lower the sodium too rapidly. So this is all about hypernatremia. Now it's time for hyponatremia. For hypovolemia, sorry, for hyponatremia, if serum osmolarity is more than 290 milliosmol per kg, if serum osmolarity is more than 290 milliosmol per kg, yes, then AM, that is advanced renal disease and marked hyperglycemia. If serum osmolarity is more than 290 milliosmol per kg and the patient has hyponatremia, then AM, that is advanced renal disease and marked hyperglycemia. If no, then do urine osmolarity. If urine osmolarity is less than 100 milliosmol per kg, then it is PM, primary polydipsia and malnutrition, beer drink or potomania. If urine osmolarity is not less than 100, no, do urine sodium. If urine sodium is less than 25, if urine sodium is less than 25, yes, then it is volume depletion, congestive heart failure, or cirrhosis. Volume depletion, congestive heart failure, and cirrhosis. If no, if urine sodium is not less than 25, then SIADH, adrenal insufficiency and hypothyroidism. SIADH, adrenal insufficiency and hypothyroidism. Hypovolemic hyponatremia. If serum sodium is less than 135, symptoms and signs of hypovolemia: decrease intake, decrease output of water, orthostatic, lightheadedness, dry mucous membrane, poor skin target, tachycardia, orthostatic hypotension. If it is extrarenal losses, that means urine sodium is less than 20. It may be due to diarrhea, vomiting, burn, pancreatitis. If it is renal losses, urine sodium is higher. It may be diuretics and mineralocorticoid deficiency. If it is decreased effective circulating blood volume, maybe due to congestive heart failure and cirrhosis. Now the must know box. If urine, if serum osmolarity less than 275 milliosmol per kg, then you have to see the volume status. Like, is it hypovolemia, is it euvolemia, is it hypervolemia, or is it variable? If it is hypovolemia, that means urine sodium is less than 40. If urine sodium is less than 40, non-renal salt loss like vomiting, diarrhea, dehydration. If urine sodium is more than 40, it is renal salt loss, diuretics, and primary adrenal insufficiency. If it is euvolemic, urine osmolarity is less than 100. Urine osmolarity is less than 100. It may be psychogenic polydipsia and beer potomania. If urine osmolarity is more than 100 and urine sodium is more than 40, it is SIADH. So urine osmolarity more than 100, urine sodium is more than 40, it is SIADH. And if it is, and in hypervolemic hyponatremia, it may be due to CHF, heart failure, so CCF, cirrhosis, and nephrotic syndrome, and some variable cause of hyponatremia. It may be pseudo hyponatremia, paraproteinemia, hyperlipidemia, and there may be hyperglycemia, exogenous solute. Okay, why would a patient with hyperosmolar hyperglycemic state have hyponatremia? It may be pseudo hyponatremia due to hyperglycemia. So it is pseudo hyponatremia due to hyperglycemia. Need to correct sodium 2 milliequivalent for 100 milligram per dl, that glucose is above 100. That means sodium is 128 and glucose is 800. So actual sodium is 128 plus 7 into 2 equal to 142. So this is the calculation. That means how we can calculate actual sodium in case of HHS. In HHS, like if sodium is 128, if sodium is 128 and glucose is 800, for above 100, 100 milligram per dl equal to 2 milli equivalent of sodium. So it is more than 100. So 128 plus 7 into 2, that means for 142. That means for 100 it is 2 milli equivalent. For 700 it is 7 into 2, that means 14 milli equivalent, and plus 128, that is 140. Okay, not a very difficult calculation, but it is very atypical, not done in day to day, not done in day to day calculation. That's why I have done. Okay, iatrogenic hyponatremia, hypotonic fluid dehydration, children, premenopausal woman, elderly, hypoxia, central nervous system disorder, clinical presentation, headache, nausea, vomiting, encephalopathy. In iatrogenic hyponatremia, give hypertonic saline 3% saline, Serial measurement of electrolyte increase serum sodium 6 to 8 milliequivalent per liter in first 24 hours. Okay, what is the likely diagnosis? Young female with orthostatic hypotension, hyponatremia, hypokalemia, orthostatic hypotension, hyponatremia, hypokalemia urine sodium, with high urine sodium and high urine potassium. It may be due to diuretic abuse. So high urine sodium and potassium, it may be due to diuretic abuse. Normally dehydrated patient with hyponatremia and hypokalemia will have reduced sodium or potassium. Correction of serum sodium, both hypo and hypernatremia should not be exceeded a rate less than 0.5 milliequivalent per liter per hour. So it should not exceed 12 milliequivalent per liter per 24 hours. Okay, adaptation to normal brain volume, extrusion of osmolytes from brain cell typically within 48 hours. Acute hyponatremia less than 48 hours is poorly tolerated. Patients are at risk of a brain herniation. Therefore, patients with serum sodium less than 130 with any symptom elevated ICP should be treated with hypertonic saline, should be treated with hypertonic saline bolus to correct serum sodium. Because neural adaptation have not occurred and patients are a relatively high risk for osmotic demyelination syndrome. Chronic hyponatremia more than 48 hours, typically better tolerated. Hypertonic saline is often reserved for those with severe hyponatremia less than 120, severe symptoms, seizure and intracranial pathology, masses and hemorrhagic stroke. Symptoms of hyponatremia on the severity of the depletion and the acuity of the onset. Diuretics are a common cause of symptomatic hyponatremia. Thus, patients should have sodium concentration monitored after initiation. If hyponatremia develops, diuretics should be discontinued. So that is all about hypo and hypernatremia. Hope you enjoyed.